Hello everybody, welcome back to DaVinci Academy's Chapter 7 of the Head and Neck. Here we're going to talk about the cranial nerves. So, the cranial nerves are a very difficult conversation to talk about for a lot of students and a lot of people because it's very complicated. There's a lot of mixed motor, mixed sensory, autonomic functions. They come from different places, they go to different places. It can be overwhelming. However, what I really like about the cranial nerves is that once you understand what each cranial nerve is and what each cranial nerve does, it makes picking up on these focal neurological deficits very, very easy, very, very quick. And just kind of processing through these are important because it's something that actually presents very, very commonly in clinical situations. So when I talk about, or when I think about the cranial nerves and the fact that there's 12 of them, I split it up into 3 groups of 4 nerves. So that's 4 coming off of the midbrain or above, 4 that are coming off of the pons, and then 4 that are coming off the medulla and below. And pretty much in sequential order, it's exactly how they were numbered. So 1, 2, 3, 4. And then you have 5, 6, 7, and 8. And then you have your last 9, 10, 11, and 12 coming off of the medulla below. So all these come off the brainstem, except for 2 that come off the brain. Number 1 and 2, which is your olfactory and your optic, these come off of the brain. All the other ones pretty much come off of the brainstem. And so they pretty much are called brainstem nerves, but they call them cranial nerves. And they all pass through little foramina that we'll discuss in a second. And again, even though they do have a lot of variety of different functions, motor, sensory, autonomic, and whatnot, we're going to walk through what each of them does to help you kind of process this. And another very important tool that I felt very useful and very helpful is isolating these nerves within the brainstem. It's probably for a topic for a different chapter, but anyway, we'll just discuss it real quickly. When you talk about the cranial nerves, it's often very difficult to isolate, which cranial nerve is coming off from where based on the brainstem. But if you use the rule of 4, so this is one rule of 4, and then another rule of 4 that's important is factors of 12. So 12, 6, 4, and 3. These are all considered to be in the midline, in the middle, right here, of the brainstem. So because of that, 3, 4, 6, and 12, you could understand that if those are knocked out, something's going wrong with the middle or the medial portion of the brainstem. And that's just another rule of 4 to keep in mind as well, especially when you're talking about where they could possibly be going wrong with the brainstem. Anyway, brainstem, neuroanatomy, that's for a different topic. So now we're going to run through these cranial nerves, and then we'll explain it in our chart format what they do. So cranial nerve 1 is the olfactory, comes off the brain. Cranial nerve 2 is the optic, comes off the brain, controls vision. Cranial nerve 3, ocular motor, pretty much as the word describes, controls the motor functions for the eye, as well as also has some parasympathetic innervations for help with constriction of the pupils and relaxation of pupils, as we'll discuss later. Then you have the trochlear nerve. Comes from the etymology of the word for a trochlea, which is like a pulley system, and that's exactly what this is. This is a pulley. This is a pulley for the eye. Then you have the trigeminal nerve, which is a big, massive nerve that actually has 3 divisions like this. And then based on these segments, they go to different portions of the face. And they're pretty much named sequentially, just like the cranial nerves are named sequentially. So V1, the first one, is the ophthalmic region, so it covers pretty much like the eyes and forehead region. Cranial nerve V2 covers the maxillary region, pretty much where the maxilla is, the nose, that kind of associated area. And then V3 covers the mandibular region, so the lower chin, lip, and then the mandible itself. So we'll discuss what each of these do in detail in a second. To continue with the cranial nerves, you have cranial nerve 6, which is the abducens nerve, which is another extraocular muscle. Then you have cranial nerve 7, which is the facial nerve, and this provides innervation to the facial muscles for facial expression. Then you have the vestibular cochlear nerve, which is cranial nerve 8, and this pretty much, as the word describes, provides innervation to the vestibular system to help with balance and position in space. And the cochlea, which is what your hearing comes from. So it literally helps with balance and hearing. Cranial nerve 9 is glossopharyngeal. This is a big parasympathetic nerve. It also has some mucosal sensation innervation and also otic innervation. It has a little bit of motor innervation, but it's mostly notorious for the fact that it's involved in mucosal sensations in the oral area. Vagus nerve is probably the most important one because this is the one that actually descends down from the brainstem all the way into pretty much the gastrointestinal, thoracic, and even abdominal cavities to help innervation for parasympathetic reasons. Then you have the accessory nerve, which is pretty much just a motor nerve that provides innervation to the trapezius and the sternocleidomastoid. That's cranial nerve 11. And then the last one is cranial nerve 12, which is the hypoglossal nerve, which provides innervation to the tongue muscles. So now we're going to break them down a little bit more. And then there's a lot of different mnemonics that people use, whether it's sensory, motor, all this stuff, whether it's both. That's great, and you can use them, and you can look them up on your own, but I found it just very useful to just kind of sit down with this material, take an index card, kind of cover all of this and then kind of quiz yourself as you're going through this. So I would cover, sensory, olfaction, no, and then cribriform plate. And then I would just kind of read it myself. All right, this is the olfactory nerve. This is cranial nerve 1. What's the motor or sensory? Sensory. What's the function? Olfaction. Smelling. And what is it? Is it autonomic? Absolutely not. And where does it pass through in the brain? The cribriform plate. And that's how I work it. And to me, that works pretty well. Because if you use mnemonics, especially in something like this, it can get very difficult, especially when you're asked on the fly, what does this do? What is this? What does this affect? If this lesion is knocked out, how's it going to present? It can become very difficult. So kind of just work with this, go with this slowly, learn your nerves, learn the function, and learn where they come from, and you'll be great. So, as you mentioned, the olfaction and controls, the smelling ability. It's pretty much localized in an area called the cribriform plate, which is this little almost like perforated piece of bone, of the ethmoid bone that actually passes into the nasal cavity. Then you have the optic nerve, which is this, again, just a sensory. It controls vision. It just goes to the optic canal of the eye in the orbit. So these two nerves are pretty slam dunk, easy to know, easy to recognize, especially when lesions are knocked out. Then you have ocular motor, which is cranial nerve 3. This pretty much has motor and it has parasympathetic. So those are the two big things you're going to want to know. It controls majority of the extraocular muscles I will discuss later, and also controls pupillary constriction, and it passes through this superior orbital fissure. So when you look at the back of the eye in the orbit, as we'll discuss in the orbital chapter, you got two fissures. You got the superior orbital fissure and you got the inferior orbital fissure. The one with most of all the big nerves are going to be through the superior orbital fissure, and just know that. You got the nerves, you're going to go through the superior orbital fissure. If you got the inferior orbital fissure, you're going to get a lot of accessory things, little branches here and there, but nothing as significant as the superior orbital fissure. Okay? So we'll go to trochlear, which means pulley. It pretty much is a motor. It just moves only one muscle, superior oblique. It has no autonomic functions, and again, passes through which fissure of the eye? The superior orbital fissure. Then you got the ophthalmic, which is V1, which is one of the segments of the trigeminal. This is only sensory. It provides sensory to the eyes, face, scalp, forehead region. No autonomics. And again, which fissure? Superior orbital fissure. Then you got maxillary. This is V2. It's, again, only sensory. No motor. And it provides a lot of sensation to the midface, where the maxilla is. No autonomic. And it goes through an area called the foramen rotundum. This is where it kind of get a little hairy, especially when you're talking about rotundum, the ovale. But again, just maxillary rotundum. Then you got the mandibular, and this is the only one of the trigeminal that has both motor and sensory. That's it. Motor and sensory. It provides muscles of mastication that we'll discuss later. It also provides sensation to that lower jaw, buccal area, gums, mandibular teeth region. Again, no autonomic. And then foramen ovale. Again, this is probably difficult. Remember, max, rotundum, mandibular, ovale. Okay? Next, we go to the abducens, again, which we discussed before. It just pretty much provides motor to just the lateral rectus, no innervation. And which fissure, if it's going to go to the eye? Superior orbital fissure. Very good. So next one, we got the facial, as we discussed before. It has both motor and sensory. It provides the predominant motor to all the facial muscles. That's the most important one. It has 5 branches that we'll discuss in a hot second. Then it also has sensory, but it's very, very important sensation to 2/3 of the tongue for taste sensation. It also helps with parasympathetic to the glands like lacrimation. It also helps with salivation as well. It also helps with innervation of the stapedius muscle. And they love to test the stapedius muscle. It's this little muscle that exists in the ear that really has no greater function except for tampering down sound. So for some reason, if you have someone that comes in and for some reason starts complaining like everything's loud, everything's just amplified so much, the volume is just, I can't turn it down, I can't cover my ears, then you think, then there could be something going wrong with the facial nerve, especially if they have other sort of facial weakness present. And as we mentioned before, it does have autonomic functions because it helps with innervation to glands like the lacrimal gland. And then where does it pass through? It comes through the internal auditory meatus. That's where it exits the skull. Then you have the vestibular cochlear, which is again cranial nerve 8. It helps with balance, position on space, and as well as hearing. So what is all that? That's all sensation. Those are all sensation stuff. It has no autonomic functions, and it passes with cranial nerve 7 and through the internal auditory meatus. Then you got the 3 that I always clump together based on where they come through the brain, the jugular foramen. So your 9, 10, and 11, they pass through the jugular foramen. And why is it called the jugular foramen? Because you also got your jugular venous system from the internal jugular vein passing along with it. So that's why this structure in the skull is so important, because it has 3 big structures of nerves and then 1 big jugular vein actually passing along with it. So glossopharyngeal, again, has mixed functions, has motor and sensory. Motor to the stylopharyngeus, which is the muscle that actually just attaches from the styloid process. It has taste sensation to the posterior 1/3 of the tongue. So anterior 2/3, facial. Posterior 1/3, glossopharyngeal. It helps with salivation, so that's why it's going to have autonomic function. It also helps with carotid body and sinus receptors, so this helps with regulation of blood pressure, and also has sensation to the middle ear. So this is like a very important nerve. Then you got the vagus, which was a pretty massive nerve in terms of importance and functions. It has motor and sensory and autonomic. So your 9 and 10, I mean, they have it all. They have motor, they have sensory, they have autonomic. They have everything. Your vagus is what provides motor to your palatal-glossus, which is one of your tongue muscles. It also helps with the pharyngeal constrictions during swallowing. It also helps with elevation of your eustachian tube. Helps with overall swallowing. Provides sensation to the middle ear, but via an artery called Arnold's artery. And then you also have parasympathetics, also important for abdominal organ, GI function as well. And then carotid arch receptors help with, again, what is that? Blood pressure regulation. And again, jugular foramen. And then accessories, just like cranial nerve 1 and 2, it's very focal presentation. It just innervates the trapezius and the sternocleidomastoid and just helps with movement of the head. And that's pretty much it. Accessory is not going to do much more than that. The one thing they may test on is the fact that it has fibers coming off from the, C1 region, the cervical region, as well as it has coming from the brainstem itself. So it has mixed both cervical, spinal cord, and brainstem. And that's important to know about the accessory. But overall, you're going to get tested on trapezius, sternocleidomastoid getting knocked out, what nerve is affected, accessory, where does it come from, leaving the skull, jugular foramen. That's the kind of stuff you're probably going to get asked more or less rather than saying, what is nerve roots? But it's also important to understand where it's coming from as well. And then finally, you have your hypoglossal, and this moves all the motor to the extrinsic tongue muscles, help with the tongue move, making things like swallowing or bending and shaping it during phonation as well. And it goes through pretty much the easiest one of all. It's called for itself the hypoglossal canal. So now we're going to go through all the cranial nerve foramina as we've just discussed all the nerves. So there's 3 regions of the skull that you kind of need to know. As we mentioned before in the osteology chapter, you got your anterior portion, and you got your middle, and then you got your posterior. And these 3 regions actually help with understanding which the cranial nerves are coming through. So first we'll talk about the anterior cranial foramina and work our way posterior. So the anterior cranial fossa is the most anterior portion of the skull, surrounded by the frontal bones. It's also composed of, surrounded by the ethmoid inferiorly. So this is the ethmoid right here. This would be half of the ethmoid right there. It also has a small wings of the sphenoid and also the orbital plates of the frontal bone, as we discussed. So the first one that's important to know is the foramen cecum, which is this little hole right here, as you can see. The superior sagittal sinus actually passes on through here. So it's important to know for that purpose. It's just a venous connection. Then you have the cribriform plate, and this is what we discussed before. This is where your olfactory nerves actually will pass through into the nasal cavity. So if you imagine this is like your cribriform plate right here, and then this is your brain cavity, your anterior cranial fossa, and then right here is your nasal cavity. What happens is the olfactory nerve actually has penetrating fibers that pass through this cribriform plate as they enter into the nasal cavity. And that's pretty much where the olfactory nerve passes through. Then we're going to talk about the middle cranial fossa. So this one lies a little more deeper and posterior to the anterior cranial fossa. It's composed of the lesser wings of the sphenoid, temporal, petrous, and parietal bones, as well as the greater wings of the sphenoid. You need to know all these names of it, maybe not, depending on what your class teaches. But in terms of a clinical examination, you're never going to get asked about what the bones are of the medial cranial fossa, the anterior or the posterior cranial fossa. You're going to need to know what these foramina do. So with the middle cranial fossa, you have the optic canal. And again, this is where your cranial nerve 2 for optic nerve for vision is housed, as well as the ophthalmic artery, which is the first division of the internal carotid artery as it passes on through the brain. Those are the 2 big things that kind of happen through the optic canal. The ophthalmic artery actually gives off a lot of branches that helps with vascularization of the eye. So if you were to occlude the ophthalmic artery for any reason, you'd go blind. Your retina would actually die because it needs and depends on constant vascularization. Then again, we get to the big gun, the superior orbital fissure. So again, the superior orbital fissure is what carries all these really big cranial nerves, these early cranial nerves, 3, 4, V1, 6. These are the ones that you're going to expect to see. It's kind of hard to see the superior and inferior orbital fissure from this view, It's easier to see in kind of this view when you're looking. This is the sphenoid bone. Imagine if you're looking from, backwards from the posterior, anterior. So you're looking almost like how someone would look through their eyes. This would be these red circles. This is where your superior orbital fissures are. This is where you're going to have a lot of the structures that pass through. You're going to have your cranial nerves 3, 4, V1, and 6, as well as your superior ophthalmic vein as well. Then you're going to get to the middle cranial fossa continuations. We have the inferior orbital fissure. Again, it's one of the ones that kind of continue down below and underneath the superior orbital fissure. And it pretty much carries 4 things. Again, how relevant these are, who knows, but I'll mention them just so you understand them. It contains the zygomatic branch of the maxillary nerve. It contains the PT ganglion branches from the lacrimal gland, which is probably the most important to help with innervation of the lacrimal gland. It also contains proximal or early parts of the infraorbital vessels as eventually they're coursing their way to the infraorbital canal. And then it also contains the inferior division of the ophthalmic vein, where the superior division goes to the superior orbital fissure. From this angle, it's hard to see, but this is superior, then inferior would be kind of looking underneath it. It's probably easy to see from the outside looking through the orbital cavity that way. So when we get to the orbital chapter, I'll mention it then. Then you got foramen rotundum. This is where your cranial nerve V2. This is where you have your maxillary nerve passing through. It's, again, easier to see in this image right here. This is where your maxillary nerve passes through on its way into the PT fossa. Then you have the foraminal valley. Again, it's hard to really visualize in this situation. You can see it right here, actually. This is your foraminal valley right here. This is where you get your mandibular nerve passing through. It's easier to see here. This is where your mandibular nerve passes through on its way into the infratemporal fossa. So, next is you have the foramen spinosum. Foramen spinosum is it doesn't really carry specific large cranial nerve itself. It carries the middle meningeal artery, the middle meningeal vein, which provides vascularization to the meninges of the skull, and also contains the meningeal branch of the cranial nerve V2 of the maxillary nerve to help with innervation sensation for the meninges. And it also is located right down there, right inferior lateral to the foraminal valley, and also enters into the infratemporal fossa. Then you have the foramen lacerum, and this is often tested because people get it confused that the internal carotid artery passes through it. It actually doesn't pass through the foramen lacerum, it passes by the foramen lacerum. If you imagine this is the internal carotid artery, right, it makes it almost like a 90-degree turn, enters into the internal carotid canal, which is this right here. This is the internal carotid canal, and then actually will pass in and then back into the skull like this. So that's how you would expect to see the internal carotid artery passing into the skull. So it makes this 90-degree turn if we're overlooking underneath. Then you have the skull right here, and then it makes a 90-degree turn and goes up into the skull itself. And then this hole right here would be the foramen lacerum as it's passing by the foramen lacerum. So not necessarily through the foramen lacerum, but by the foramen lacerum. And then you have your canals of the lesser and greater petrosal nerves. And these are those nerves that also enter into the PT fossa. And again, it's hard to visualize. It's a little vessel that is like almost considered like here, a little canal that allows for entranceway into the PT fossa. Now we're going to talk about the posterior cranial fossa. This is composed of bones of the occipital, parietal, squamous, and massive process of the temporal bone. It's important because it contains the inferior acoustic meatus, which is where cranial nerves 7 and 8 pass through. Also the labyrinthine artery, which is a blood supply that gives blood to pretty much all the inner ear. It also has the external acoustic meatus, which is the outer portion of the ear. So it's often tested that the internal acoustic meatus and the external acoustic meatus, although they are named very similarly, actually are not a communication. The inferior acoustic meatus actually will terminate, and the external acoustic meatus actually has no means of connection through the internal. It actually has to pass through a bony channel and then enter into the external acoustic meatus to get to the outer ear. So they do not communicate. Internal and external do not communicate whatsoever. Then you have the posterior cranial fossa continuation, where you have the jugular foramen, as I mentioned before. You have your 3 big nerves, and you got your 1 big vein. You got your cranial nerves 9, 10, and 11, and you got your jugular vein as it descends into the neck. Those are the big 4 guys right there where that circle is, right next to the foramen magnum. You're not going to get this one wrong. Even when you're looking, bird's eye view of the skull like this, or when you're looking outside view at the skull, you can pick up the jugular foramen pretty easily because it's a pretty massive one. Hypoglossal canal is actually a really difficult one to spot. It's often missed. People often get confused. It's going to be one little nerve, so you're not going to expect it to be a very large foramen. It's going to be one little nerve, cranial nerve 12 passing its way through. And then you have the big one, the last one, the largest foramen in the skull. This is the foramen magnum. This is where your medulla oblongata, this is where your brainstem will actually become the continuation as a spinal cord. And this is where you get the spinal root of the accessory nerve as it passes up through the foramen magnum. So imagine if the cranial nerve is passing up through here and then wrapping around and coming through the jugular foramen. That's how the spinal roots of the cranial nerve 11 would happen. So now we're going to go discuss like the clinical lesions that are associated with all this. And these are so important. This is probably one of the most important chapters in all of head and neck because this is so easily tested because of the fact that there's just so much content involved. So we're just going to kind of break this down and explain situations that this can happen and how they're going to present. So we'll talk about the cavernous sinus. This is going to be tested upon from now to the end of time. So the cavernous sinus is this region that's located pretty much right around here surrounding the pituitary gland, and it's just a almost like a lake of venous blood, and it's pretty much just draining blood from the midface, the eyes, a lot of their surrounding neurological structures, as well as the pituitary gland, and it just continues to transport this blood posteriorly like this until where it gets to the sagittal sinus system and eventually into the internal jugular venous system. And what happens is because it drains a lot of the midface and eyes surrounding things, you can get a lot of bacteria that will actually flow into the cavernous sinus and actually end up causing clots, thrombosis. Infections can cause local inflammation and masses that can form. Or even if you have some sort of trauma that actually disrupts the cavernous sinus for any reason, you can, in a sense, disrupt any of the cranial nerves that are passing through this cavernous sinus. And what cranial nerves are those? So you got a bunch right here. So you have your cranial nerves 3, you have your cranial nerves 4, you have cranial nerves V1, which is your ophthalmic, and cranial nerves V2, which is your maxillary. And then you also have cranial nerves abducens. So the ones that are along considered the wall would be these guys right here. This is your oculomotor, your trochlear, you have your ophthalmic, your V1, and your maxillary. These are the ones that are all associated within the wall of the cavernous sinus. Then the one that's kind of floating in the middle of the cavernous sinus is your abducens nerve. And this is the one that's often tested upon because if there's some sort of clot here, it's going to disrupt which nerve most likely? It's going to disrupt the abducens nerve. Or if you have some sort of calcification of your internal carotid artery for some reason and this gets thicker, and it's going to end up compressing your abducens nerve. So you can expect any associated complications to happen when you have some sort of disruption in the cavernous sinus to any of these nerves. So the clinical presentation can vary significantly. However, just keep in mind, if you're seeing a lot of these kind of nerves, which nerve is injured, what's happening, think cavernous sinus. And the way I break down clinical situations is when I'm reading a vignette or a clinical situation or looking at a patient with a clinical problem, I look to see what do they have wrong with them and what is its immediate association. So then I can start listing things like, okay, we got a disruption of V1. We also have a disruption in some cranial nerve 3, and this person most notably can't move their eye laterally, so then abducens is obstructed. So I'm thinking and looking at, these are very different structures. They all happen to have something associated with probably like superior orbital fissure, something, maybe really close proximity to that. Then you're going to work things through, like looking at the history that, they had really bad acne, they picked their acne, and and that can be an indication. The white blood cell count's super elevated, you're thinking infection, and then you think cavernous sinus disruption. So next we're going to discuss extraocular lesions. With the eye, you have these muscles that actually attach to the surrounding structures of the eyeball itself that actually help move the eye up, down, left, right, and actually in a rotational, angulated manner. At first glance, it's actually very difficult to kind of figure out, what are these different extraocular muscles doing? But actually, when you break them down by what they do, it's actually very easy to follow. We'll discuss what a lot of these extraocular muscles do in specific detail in the eye and orbit chapter, but we're going to just break down how they're going to present real quickly. So again, here are kind of like your extraocular muscles attaching to the eye. So when we talk about cranial nerve 3 lesions, it's important to know what does the cranial nerve 3 innervate. Well, it innervates the medial rectus. So imagine if this right here, this is the nose right here, as you can see the nasal bone. So this would be your left eye. So right here, this would be your medial rectus. This is your superior rectus. This is your inferior oblique right here. And then you also have your superior oblique right there. Then you have a muscle that actually overlaps all this like this. And it's called your superior tarsal muscle, which helps with elevation of the eyelid. So if you would expect just global disruption of a lot of the extraocular muscles, then you're going to think cranial nerve 3 lesion. It's very easy to kind of pick up and very easy to note. But what happens if all these muscles are gone, the muscles that are still left are going to be the predominant force. So what's left? You got your abducens, which moves your eye this direction. So you're going to expect your eye to kind of be out and looking laterally, right? Your superior oblique, which is by your trochlear, is still going to be working. This moves your eye down and in. If you expect your trochlear to work, which moves it down and in, and you expect your lateral rectus to work, which moves it out, you're going to expect your eye to kind of work in like this. You're going to expect your eye to be looking in this direction, down and out. So that's classic. That's how you get to it. But down and out, that's when you're going to look at someone's eye and you're going to say, this probably looks like a cranial nerve 3 lesion. So I try to walk you through how you're going to get a down and out lesion, because your lateral rectus and your superior oblique are going to be the dominating forces, and their vectors are going to be so strong it's going to push the eye down and out. So now we're going to talk about the cranial nerve for the trochlear nerve, the superior oblique, when that's injured for some reason. Like I mentioned before, your superior oblique literally makes you look down and in. This is the nerve that kind of pulls in a pulley manner, kind of rotates the eye in a circular direction like this, and then makes you look down and in. That's how the eye works. So when you look down and in, this person's going to present, when I go out of the car and I look down on the ground, I stumble or I fall, or for some reason I have trouble going downstairs, I see double vision, it's not working right, I can't see where I'm walking. Then you're going to suspect superior oblique, because it moves the eye down and in. And it's not strong enough to where it's going to actually have a significant notable defect. You could have the eye looking in a different direction, or it can be very normal and just presents with double vision and difficulty going downstairs. That's often how it even presents in a clinical situation. So now we're going to talk about our abducens nerve. This is our lateral rectus. This is just this one little muscle over here on the outside. It just helps look the eye outward. So you're going to have trouble looking laterally. So if you move your eye, do an eye test, and you're moving your eye left and right, this is the one that the eye is not going to be able to track laterally with, and that's easy to pick up in itself because there's no other associated problems with cranial nerve 6. It's just the lateral rectus. So now I'm going to talk about the trigeminal nerve. So this is a big nerve with 3 different branches that have a lot of different functions here. So the trigeminal nerve is pretty much sensory and motor, no parasympathetic. So we're going to talk about the sensory loss first. So all 3 branches of the trigeminal nerve have sensory functions. So as we discussed before, V1, this is going to have sensation to the forehead, the external orbital areas. It's going to help with corneal reflex, dorsal nasal areas. So everything in green here, you're going to expect to be the ophthalmic division. So if this is knocked out, you're going to have just decreased sensation in this region. You're not going to be able to look at the eyes. When you touch the eyes, corneal reflex, eyes won't blink or flinch when you touch their eyes. Very easy to pick up. Then you have V2. This is where you have your maxillary. This is going to be the one in pink right here. This one, you have loss of sensation to the infraorbital area, your maxillary region, your upper lip, your lateral nasal areas, your medial and lateral cheek, and your maxillary teeth. This is the one that's also going to be very easy to present because it's only sensory. So if you have sensory loss in any of this region, you're going to easily be able to pick it up. Then you have sensation to your mandibular one. This is when you have things here in yellow. This is stuff that's going to be loss of sensation to the lower lip, mandible, the cheek region. But you can also have loss of sensation to your teeth, so they can feel numb, or they can feel like hot and cold test is not working right. So that can be easy to pick up in that way. What's important to note is that it's actually at this very little region right here. The angle of the mandible is not actually controlled by the mandibular branch of the trigeminal. It's actually controlled by the cervical branches, the cervical nerves. When you try to test someone in terms of their mandibular function, make sure you don't go to the angle of the mandible, because you're probably not going to accurately tell if this is a mandibular structure lesion or this is a cervical nerve structural lesion. So now I'll talk about motor. So when we talk about motor and trigeminal, it's only V3. It's only mandibular. There's no other branch of the trigeminal that has any motor functions. The motor functions for the mandibular is pretty much all the muscles of mastication. So this is all the muscles that allow you to chew your food, move your jaw. This is what's controlled by V3. There are 4 muscles of mastication. You have your temporalis, you have your medial and lateral pterygoid, and your masseter. And those are your 4 muscles. We'll discuss them later in the muscles of the head and neck chapters, but anyway, we'll discuss it briefly here. The way I think of it is in 2 ways. You have your ability to munch your teeth, right? So you bring your teeth up, and you have your ability to move your teeth down. The muscles that allow you to munch your food all have an M in it. So medial pterygoid, temporalis, masseter, those are the ones that all allow you to move your jaw up and munch your food. And the only one that allows you to depress your mandible or bring your jaw open is your lateral pterygoid. Okay? So keep that in mind. Munching your food, it's all the muscles that have an M in it. Temporalis, medial pterygoid, masseter, and then the ones that allow you to depress your mandible, that is the lateral pterygoid. So, as we mentioned before, M for munching, temporalis, medial, and masseter. So what's interesting is that this is a very unique presentation. So if an individual presents with some sort of lateral deviation of the jaw, so the jaw is, this is the teeth, and then their mandible is off center like this. When it's some sort of lateral deviation of the jaw, it's usually some sort of presentation going on with ipsilateral pterygoid muscle that's impaired. So the pterygoids aside from also helping with moving the jaw up and down, actually help with keeping the jaw in a midline position. So what happens is if the jaw is deviating to the right-sided pterygoids, for whatever reason, have lost the ability to pull the jaw back towards midline. So if you would expect, this is fixed. Your maxillary teeth are always fixed. It's only your mandible that can move. So if your mandible is moving over to the right, what happens is the problem is your teeth are not lined anymore, so it's not being able to be drawn back to the middle. So you have a problem with your right-sided pterygoids because it cannot draw the teeth back this direction. It can only draw, the forces are so dominant in this direction. So just think, if your jaw is deviating to the right, it's your right pterygoid. If your jaw is deviating to the left, it's your left pterygoid, just ipsilateral side. And because it's just the compensatory vectors are so strong. So that we'll talk about the facial nerve lesion. So again, the facial nerve is important because it provides all the muscle of innervation to the facial expression, and it's very important, especially when picking up something like a stroke. And also even get injured in things like parotid dissections, parotid tumor removals, anything involving dissections near the external auditory meatus, or even something like a facelift can disrupt the facial nerve branches. And what's unique is that the facial nerve actually has almost like direct upper motor and lower motor neurons to different regions, and we'll discuss that in a second. So these are your branches. So we'll discuss in later chapters. But your facial nerve is composed of 5 main branches. You have your temporal branch, you have your zygomatic branch, you have your buccal branch, you have your marginal mandibular branch, and then you also have your cervical branch. So this is what pretty much controls all the muscles of facial expression, are these big 4 branches. The cervical branch controls the platysma, which is also considered to be a muscle of facial expression, but it's pretty much, platysma is innervated by the cervical branch of the facial, and that's pretty much all that cervical branch does. So for any reason whatsoever, you can knock these branches out. So if you imagine, if you cut the nerve right here, then you would pretty much knock out all facial expression on this ipsilateral side. And then right here, this is your posterior auricular nerve. This just provides sensation to the posterior portion of the skull, right behind the ear. The upper motor neurons actually provide innervation to 2 regions, the upper and the lower. So when they're knocked out, it presents differently than the lower motor neurons. So the upper 1/3 of the forehead is actually made up of bilateral cortical inputs. The middle and lower 1/3 are actually made up of unilateral cortical inputs. So how does that present? So in order to determine the localization of cranial nerve defects, as in either an upper motor or a lower motor neuron lesion, you first have to figure out what part of the face is injured. Do we have the whole one side of the face, both forehead, mid, and lower, or do we just have mid and lower? If you just have only the mid and lower, you're going to have an upper motor neuron lesion that's affected. If you have all of the whole face that's affected, then you're going to expect to be a lower motor neuron lesion because, like we mentioned before, if you would clip that nerve as it's coming out of the external auditory meatus, you're going to affect all the nerves going up from the forehead down to the jaw. Whereas the upper motor neurons, since they have bicortical, so they have a region over here and a region over here going like this. If you were to clip this, you're still going to be able to move the forehead. If you were to clip this and this is still intact, you can still move the forehead. So that's what it means. So what happens now is if you were to clip the nerve coming out of the ear, going here, here, and here, and you clip it right here, you're going to have no ability to move any of these structures. So now we'll discuss the auditory lesions. So again, this is composed of just affecting the ability to hear and the ability to balance and keep your positional sense. Auditory lesions are really difficult to purely state as neurological in nature due to the way in which sound is transmitted. It can be transmitted either through bone or it can be transmitted through air, and that's what makes it very difficult to figure out is this a neurological problem, sensory neural problem, or just like a conduction problem, something with your ability to get sound in. It's earwax, your middle ear is not working properly. The biggest way to do this, to test is this sensory neural or is neurologic or is this conductive, is to use a test called Weber and Rhine tests. Kind of break it down from here. So usually your normal hearing is where you hear sounds through air better than you do through bone, and that's just physics. And so what happens is you expect to hear sounds better this way when you use something like a tuning fork. You take a tuning fork, which is about 512 hertz, you hit it, you cause it to vibrate, and then you place the tuning fork right at the mastoid process behind the ear. In a normal individual, you would listen to this sound until it goes away. It's absent. Then you take the tuning fork, you place about 1 centimeter outside away from their ear canal, and they should still be able to hear it. They should still be able to hear this ringing sound going. And that's normal. If you hear it in the bone, goes away, and then you put it in front of the ear and it's still ringing, that's perfectly fine. That's a normal Rhine test. However, it's not always that confirmatory. You need to use the Weber to confirm, is this normal hearing or is this sensory neural loss? So what you do is then you do the Weber test. So you take the Weber test, you hit it, you place it right over top of the forehead, And then if it lateralizes to any side, that's considered to be the normal ear it's lateralizing to. So if you, for some reason, you do the Ryan test and bone is actually greater than air, so it actually sounds louder when you have it in the mastoid process, then you put it in the front of the ear and you can't hear it at all, that's considered to be an abnormal test. That's not normal. You needed to hear it through air longer than bone. So what happens now is then you confirm with the Weber test, and we put the Weber test and you put it on their forehead and it lateralizes to an ear. That's going to be the abnormal ear. So that's the way I remember it, is if the Ryan test is abnormal, the Weber test is going to lateralize to the abnormal ear. And that's kind of how I broke it down, and that's how it's actually easy to kind of think about it in a clinical situation, because this actually can be very difficult. If you remember what normal is, and you remember what abnormal is, then you can figure out is this conductive or sensory neural hearing loss. So again, if you have normal hearing, air is going to be longer than bone, and Weber is going to lateralize midline to the middle on both sides. If you have sensory neural hearing loss, it could sound like air is greater than bone with a Ryan test, but you're going to lateralize to a normal ear. So the one ear that can't hear is one that has the neural problem. Then if bone is greater than air, that means you have a conductive problem. So it's pretty easy to pick up on that, and just you confirm it with the Weber to see if it lateralizes to the abnormal ear. Now I'm going to talk about some oropharyngeal lesions, especially when we talk about cranial nerves 9, 10. So these lesions are maybe a bit complex, but if you understand the different innervations to the different structure, it actually help with figuring out where the lesion is coming from. Taste sensation is actually a very common one. And again, like we mentioned before, if you have loss of taste sensation to the anterior 2/3, boom, easy enough, cranial nerve 7 is knocked out. If you have loss of taste sensation in the posterior 1/3, easy enough, pharyngeal nerve is knocked out. And then if you have some sort of taste sensation that's lost deep back near the epiglottis, where there's still some taste receptors, that's going to be vagus. So that's how taste sensation presents. So kind of working your way back. So this is like 7, this is going to be 9, and then way back here, it's even hard to see down in this recesses here near the epiglottis, that's cranial nerve 10. So that's how you know which nerve is knocked out with taste sensation. So the tongue is divided into extrinsic and intrinsic muscles. So the extrinsic tongue muscles are the ones that allow you to do those big cardinal movements, up, down, left, right. And then the intrinsic tongue muscles are the ones that allow you to like roll your tongue and make a 4-leaf clover. So predominantly the extrinsic tongue muscles are all controlled by the hypoglossal nerve, except for the styloglossus, which is controlled by the vagus nerve. It's only one. The most common presentation with the tongue is you're going to have tongue deviation to the left or right. And the way that I always like to remember this is by thinking about the little saying, you lick your own wounds. So if your tongue is actually coming over like this, and this is your right side, so what happens here is it means that your right cranial nerve 12 is knocked out, your right hypoglossal is knocked out. If your tongue is deviating over to the left like this, then it's your left hypoglossal nerve that's knocked out. So pretty much whatever side your tongue is deviating towards, that's the side that's knocked out. And then you have your uvula. So your uvula also is located in the back of your throat right here. And this is the one that if it deviates to the side, that's the opposite nerve that's affected. So it's different than the tongue. So the tongue, you lick your own wounds, and the uvula, it's the opposite, the contralateral side that's injured. So the uvula is usually controlled by cranial nerve 10. When you injure cranial nerve 10 for some reason in innervating the muscle of the uvula, you lose the ability to stabilize. If your uvula deviates this way, the problem is the muscles on this side right here are not strong enough anymore because they have no innervation to pull it back. So that's what it means. The contralateral side is affected. So if this is your right side and this is your left side, and the uvula is deviating to the right, then it's your left vagus that would be injured. We'll just discuss cranial nerve 11 real quick. This is your accessory. This provides innervation to your sternocleidomastoid and your trapezius. So here's your sternocleidomastoid, and this is your massive trapezius. And these muscles just help with things like contralateral head rotation as well as ipsilateral shoulder elevation. So very easy enough to present. Someone can't lift their right shoulder. Someone can't move their head to the left. You're going to expect it, to be an associated accessory nerve lesion. Now, real quick, I'm also going to mention these cranial nerve reflexes because this is very easy to pick up, especially in someone that has, lost consciousness, whether in a coma or you may be thinking they're brain dead. Cranial nerve lesions are great because this helps you pick up where this central nervous system insult has actually happened or where it's occurring. So what are reflexes? So reflexes are stimulus-driven movements that actually are produced without any conscious thought. You don't have to have any conscious ability to think about this stuff. It's just like a reflex arc. So what happens is you have your sensory arm, and it goes to your brainstem, and it goes to your efferent or your motor arm. And what happens is if you do some sort of sensation here, it's going to go right to in pretty much like an arc, and then elicit a response before your brain even knows what's happening. So you have your pupillary response, which you sense through light, your eyes, and what happens is your pupils will constrict. That's cranial nerve 3, via the parasympathetic fibers of your cranial nerve 3. Then you have your accommodation, and this is your ability to look closely. So again, you look at something, and then you take your finger, stick it out arm's length out, and then move your finger closer and closer and closer to your eyes, and you try to keep your eyes focused. And they should be able to keep your eyes focused, and that's because your cranial nerve 3 is actually accommodating the structure of its lens to actually allow for focusing from really far to really close in without breaking that focus. Then you have your corneal reflex, which is sensation via the eye region, which is your V1 of your trigeminal, and then your response is to blink. Easy enough. And what causes you to blink? That's a facial muscle. That's your cranial nerve 7 innervation. And then you have your glabellar reflex, which is where you have a sensation right between your eyebrows. What happens is, in some people, it's kind of hard to do. It's a difficult reflex to elicit, but you can tap their glabella. And if you tap their glabella, you can actually elicit some sort of like blink as well, or some sort of movement right there. That's just a glabellar reflex. You have your jaw jerk reflex, which again, it's probably something you would do in someone who has like in a comatose state, or someone you suspect may be brain dead. This is where you tap right underneath their lower lip, right where that little crease is, right underneath their lower lip, their labiomental crease. You tap right there. Sensation signals then send back to the facial, of the jaw. Muscles of mastication will actually allow your jaw to clench. So it's not facial because it's muscles of mastication. So you tap right underneath your lower lip, and then it actually causes your chin to actually clench down. Then you have your VOR reflex, your vestibular-ocular reflex. This is where you have your cranial nerve 8 sensation. This is where it's like a position in space. So this is where if someone is like in a comatose state, and then you move their head left, you move the head right, you move the head up and down, and if their cranial nerve 8's intact, they can sense their position in space. And what happens is their eyes should remain locked in a focused position. What happens is if the eyes are no longer moving because your cranial nerve 8's knocked out, or any of these nerves are knocked out as well, you're going to get like a doll's eye reflex, in which it's not going to be able to really track as well. It's just gonna move. As you move the head left, your eyes are going to move left. As you move the head right, your eyes are going to move right. So it's kind of creepy to see, but that's your VOR reflex. And then you have your gag reflex that everyone pretty much knows about. It's just where your sensation to the mucosal lining deep in the back of your throat is by the glossopharyngeal, and then that gag sensation, that pharyngeal constriction, that guttural response is controlled by your vagus, your motor off the vagus. And that concludes DaVinci Academy's chapter of the cranial nerves. So this was a very big one. This is a very important one. This is one that it's probably worthwhile to actually go back and re-listen to, because a lot of these clinical situations and lesions are almost guaranteed to be presented in some sort of clinical situation, both testing, examination, step 1, or even in the wards, or even in your own clinical practice down the road. Thank you very much.